So, okay, so I went to a conference in October. It was the A1 biannual conference. It was in Freeport. And A1 is a professional organization, the Association of Women's Health, Obstetrics, and Neonatal Nurses, is what it stands for. So it's always a really great packed meeting with information. And so one of the topics was addressing maternal morbidity and mortality. And honestly, I was more interested in the hemorrhage topic that was going to be, and I thought this will be very dry. But then I got really interested in it. And one of the speakers mentioned that all ERs, she says in her presentation, all ERs should be asking the question on triage to every woman of childbearing age, have they been pregnant within the last year? And it goes on because of the morbidity risk factors and such. And so I happened to discuss it at our OB meeting, and Jennifer Johnson asked Chris, and Chris said no, that wasn't part of is it the T system? I'm not sure all your systems downstairs, but the T system is not a question that you guys are triggered to ask. And so Chris asked me some more information, like, what's the driving force behind this question? And really it was just, it's not written anywhere in literature saying, like ACOG is not saying this must be a question you ask. But it's really important for tracking purposes when there is a maternal morbidity occurring in the state. For the state to be able to track the incidence of the different mortality, and we'll go into the different morbidity risk characteristics. But so it's more for gathering data, okay? And then it also the death certificate. There's a question on a death certificate that is relatively new, that speaks to the different definitions for women who have died, and it speaks to and I'll get into those two, associated to pregnancy, and where it falls within the first 42 days after delivery, and then 43 days to a year. So it's very specific, but it's all part of how we can help reduce the rate of maternal morbidity and mortality in the country. So then then she said, well, would you come and speak? And so then I'm just sharing some of my little snippets that I thought were kind of intriguing from the conference. So that's kind of the impetus behind this presentation. So let's see if we can make it work. Okay, so I just put my objectives up here. I really want to, I think we do a great job. I don't think this is not targeting that we need to be, that we're doing anything wrong. It's more just for an awareness, okay? Because I think we have, luckily, we don't have a high volume of, we're not, we can increase our rates, hopefully, of deliveries, but we have a great program, return visit program, where the moms come back to us in a couple of days. Our practitioners are really seeing our patients postpartum before the 6-week mark now, versus they're seeing them at 1 to 2 weeks postpartum, where it always used to be 6 weeks, where a lot can happen in that first 6 weeks. So we're really proactive in it, but I just think the ER, you could be in a situation where, especially in those first 6 weeks, a mom presents, and if you just hear it a little bit, it might trigger you to be like, ooh, that was something that Ellen talked about. And I'm just going to help define some key terms, understanding the terminology related to pregnant women, and a little bit about the Perinatal Quality Collaborative for Maine. They're just, if we can help to identify any maternal morbidity, or hopefully no mortality, but helps them to get their data as accurate as possible. So what we know is that 840 women die worldwide every day from maternal death causes. A quarter of those happen prenatally. A quarter of them are happening intrapartum period, but a half of them are happening in the postpartum period. So that's going to be, that's a lot. And so that the first 48 hours is pretty critical time, and a lot of them are here in the hospital, so that's good. But that's a pretty high ratio there. The United States has the highest maternal mortality rate of any high resource country, and it's the only country outside of Afghanistan and Sudan where the rate keeps rising.
We've been high for a long
So
time.
we have some work to do. So what's being done in our country to help? So AIM, which is, I never had heard of this before the conference, is an Alliance for Innovation on Maternal Health. It's a national data-driven maternal safety and quality improvement initiative that it was looking at a 4-year span from 2014 to 18. And it's really focusing on equipping healthcare professionals that deal with maternal women and empowering us to implement different care practices so that we can in the care practices, it's really speaking to the maternal safety bundles. Do you guys use bundles? Have you heard of that?
But not the maternal
This
one.
is, yeah, so there's all these maternal bundles, and I'll show you a slide. One of them, hemorrhage, DVT, hypertension, all these really driving us to be a little bit more vigilant. So they're pretty awesome. So the AIM's goal is to promote consistent and safe maternal care in hopes to reduce the maternal mortality by 1,000 and severe maternal morbidity by 100,000 instances over the course of 4 years, from 2014 to 2018. And AIM has partnered with the following professional organizations, and ACOG is hugely involved with their project. And then you have the ACNM, American College of Nurse Midwives, and it goes on. A1's down there. CMQCC, California Maternal Quality Care Collaborative. They have amazing bundles guiding kind of how I've been using their resources a lot to help guide kind of our policy development. So anyway, so these are some common examples of maternal safety bundles that are, we're all encouraged to kind of get in place in our hospital. So obstetrical hemorrhage, severe hypertension and preeclampsia, the prevention of venous thromboembolism, the reduction of low-risk primary C-section birth, and really supporting vaginal delivery. So there's a big push to like VBAC situations, vaginal birth after cesarean, really getting, advocating, as long as they don't risk out, there's a lot of benefit to having a VBAC. Reduction of peripartum racial disparities and postpartum care access and standards, which again I spoke to a little bit. I think our providers are doing an excellent job in that, and they're seeing them soon after discharge. Obstetrical hemorrhage, that's kind of a huge one, but I do have a significant guideline that's kind of gone through Med Executive Committee, and that is going to be super helpful in that we're now quantifying blood loss instead of estimating, and so we're going to be hopefully with quantifying blood loss we'll be able to activate interventions a little quicker instead of waiting for how do you do it. Yeah, it's at first it was really daunting because I thought, but it's been so easy. We have a very simple process so far. We need to get into the OR. That's my next attack, because that will be, we need to be quantifying there too. But our vaginal births, as soon as the baby's delivered, we put a big orange chuck, you know, those, just, I don't know if you have those big orange ones. We slide that underneath the mom's bottom right after the baby's born. And then any blood loss, because then amniotic fluids come out, because so and so we're measuring everything after the baby's born. So so 1 gram is 1 ml. Okay. So we have the dry weights of everything, and then we just, and it's super easy. At first we thought, oh my God, because we're not octopus and we can't be doing everything, but it has not been bad at all. It's pretty cool. And then
we do that to get the doctor to pay attention. We weigh them at Maine Coast, and just to get this is a bit old.
We underestimated so much, and now we're keeping track of all of our QBLs, and we're comparing postpartum H&Hs, because we want to try to get them to not have to have that if the QBL is within a certain range. Because we're not seeing any shifts in their postpartum H&Hs. If they're like between the 250, 300 range, they're not dropping hardly at all. So it's almost like save them an extra probe. So that's our independent study, because some of the nurses are, it's kind of like, seriously, we're QBLing, like, and so we're like, well, if we can help, on this, other end, it's kind of fun. So anyway, so my slides are, I'm sorry, a little, I'm going to talk about preeclampsia right now. I feel like this is one of the big presentations that you might be faced in the ER with someone that comes in either prenatally or in the postpartum period. And so I'm sure you've heard of preeclampsia. There's a lot of new definitions. We used to say it was, they just have a mild form, moderate, or severe. And that terminology's gone now. It's now preeclampsia without severe features, or the mother, the woman has preeclampsia with severe features. And with severe features is you're going to have end organ involvement with your kidneys, your liver, headaches, and such. So it's a new onset of hypertension and protein in the urine, or you may have just a new onset of hypertension with significant end organ dysfunction. You might not have protein in your urine. So if they have high blood pressure and other, LFTs are elevated, or other organ involvement, but they don't have protein in their urine. I think before people thought, well, they don't have it, but they still could. So don't rule that out. And it usually presents after 20. It's going to present after 20 weeks of gestation in a previously normotensive patient. So if it's happening before 20 weeks, then it's not going to be classified as preeclampsia. So those are some of the symptoms, signs and symptoms you're looking for. The classic 140/90 as your hypertensive mark. Protein in the urine, swelling of the hands, feet, face, limbs, severe headaches, changes in their vision. They may see some spots, and you guys want to ask about that. And then that upper abdominal pain, usually on the right side, that could be their liver, and so it can get really masked. People having a lot of reflux problems during their pregnancy. Some women experience gallbladder problems, but really kind of looking at that whole clinical picture. And I just want to encourage, if you ever have questions, not to hesitate to call one of the OB nurses or the OB on call if you're kind of wondering if it's OB related. Complications from preeclampsia, if left untreated, undiagnosed, it can move straight to eclampsia, which is essentially preeclampsia with seizures, pulmonary edema, stroke, thromboembolism, and HELP syndrome, which is a pretty scary place to be. And HELP stands for hemolysis, elevated liver enzymes. Your platelets will be low, and it can be extremely life-threatening. And it can develop anytime during pregnancy, but you know, it's generally going to be after the 20-week mark at its earliest presentation, but generally may present closer to the 34-week marks. 5% of preeclampsia cases present postpartum, so that could be in the ER. It could be us at a return visit. So delayed preeclampsia can present greater than 2 days after delivery, but less than 6 weeks. So just always having your back of your mind that blood pressure and other symptoms. These are some labs, basic labs to consider. You know, encouraging the provider to get CBC, liver enzymes, creatinine, any urine protein collection. Okay, so I have this. This video was so powerful to me, and it's kind of sad, but it shows the importance of, like, we need to educate. We need to educate every step of every encounter we have with these moms. So I hope I can make it work.
So, but isn't preeclampsia, isn't that specifically pregnancy, a condition of pregnancy?
Yes.
So what happens, how do they get it when they have their baby already?
So this video is going to
Okay,
speak.
okay.
So most people think, and we're like, oh yeah, she's preeclamptic. We're going to get her delivered, and she's cured. And this will speak. This
Okay,
dad
okay,
speaks to that in this video. It can present up to 6 weeks postpartum.
Nice,
So that right. So it's like that's, and so this particular family was told, here's delivery, and then there was a lack of education.
Didn't they have a Call the Midwives about that?
Oh!
Call the Midwives show?
Did they? I don't watch that show, but they may have.
They had a lady with postpartum preeclampsia.
I love that show.
Yeah.
Yeah. Okay, let's hope.
Call the Midwife?
I hope it will.
So PBS, you can't.
It's really good. It's on Netflix.
Yeah. Must be on
I
Netflix.
wonder how you get the volume. See, this is my thing.
Oh, yeah,
Okay, Chris, you have to
so
do
you
it
have
too.
to turn it up on your computer.
Chris, I might need your help.
Yeah,
Oh.
you had to work some magic, Chris, when you did.
Yeah, I had some problems too.
Oh,
It's not doing that.
I can, okay,
Yeah, I think you're gonna have to go out of your PowerPoint, so go back here.
go here.
Yeah, go ahead, click on that.
You know, because I don't know if there's
Oh, you know what I
probably 4
did
seasons
before?
You know
anyway.
what, I just checked it yesterday.
Presentation mode.
Who was I working with? There's 7 seasons.
So, yeah, click out of there.
Oh,
what's
yeah.
your
Or-
It's
yeah.
just about women giving birth.
No, it's about,
The East End of London.
yeah, London,
Right,
the
that's
a World
nurses
War
and the
II,
midwives,
so.
they love live together to treat this kind of
I have
poverty-ridden
Let's
area.
minimize it there.
And
So
it's
there's-
really like a feel-good show about
Yeah.
helping
Yeah.
one another out,
Yeah.
getting them through
Okay.
hard
What is
times.
it called?
On Firefox.
Camaraderie and teamwork and all that stuff.
Oh.
It's really good.
Do you have
Yeah.
a link on that?
And aren't the midwives all
Can you open up
religious?
there?
They're
Well,
all-
no,
Some of
the
them
house,
are,
the
some of them
The
are.
house,
on
the
your
orders
side
are,
it is
okay, but
the
not
right.
all the midwives are.
Issues.
Right.
Because I watched it a few times.
See if you can get
My
that.
Copy it.
daughter
Copy it.
adores that show too.
And then
From
drop it into,
Firefox.
yeah, into the header there.
Right here.
You guys should.
Oh, I'm not.
And then
because
enter.
I needed
It's kind of
help.
that feel
There
good,
you
like
go.
all food just
And
very
then-
small.
You can
Yeah,
push that,
it
it will
is.
open it up all the way. There you go. So you're gonna just have to turn. What's that? Not sure. Why is it not? Oh, can I drive?
Yeah.
Oh, that's on. Huh,
Shoot, I might just have to.
wow.
Summarize
why
it
is
for you.
doing that?
Do you have to plug speakers in? Can you plug a
We
speaker in?
shouldn't have to.
I bet I could.
It's not muted on the thing, is it?
No, it's not, let's check. I'm gonna, Does that make a difference? That's disappointing.
If not, I can probably unplug from this whole thing and then turn this and you
Yeah.
can see it,
Yeah,
because it will.
yeah. Yeah, it's something worth watching.
We can all gather closer.
Yes.
Yeah, I will, let me try to see if I can.
There was not a whole lot.
Oh,
of
yeah, yeah, there's noise, guys. Okay. All right. So I'm just gonna turn it. Here. Can you kind of see?
Yeah.
Okay.
Wait a second, I'll move the camera.
There's no mom like you, and in this picture I can see her.
She and Sophie were extremely bonded. I mean, everything that Joan did, she had Sophie with her, and Sophie slept with us for the first 2 years. Never really thought I'd be a father. It's been quite the experience, quite the ride. It's a learning curve, but I love it. They were kind of telling us, you know, she's severe preeclampsia, but don't worry, because the cure for preeclampsia is delivery. So we're going to manage this pregnancy a little bit more. Her blood pressure is at 172/95. It's very elevated. There was not a whole lot of in-depth discussions around preeclampsia and what that could be. Everything was, if the baby's delivered, everything's going to be fine, because that's the cure for it. 48 hours later, after her being admitted, they again did a C-section on her. You know, at that point, it's like, the baby's out, your wife's going to be fine. She was not discharged by the high-risk doctor that had admitted her to the hospital. She was discharged by the third doctor, if you will. There was no discussion with the high-risk doctor about any of this. And she was sent home. There was no mention of any complications from preeclampsia after the birth. Here we are 48 hours after delivery. She's had multiple pregnancies. She's over 42. She's diabetic. She'd had in vitro fertilization. She'd had miscarriage. She'd had the issues with potassium. She had some family history behind her, so there were probably 7 or 8 red flags that should have been considered. Over the course of the next 48 hours, she was experiencing difficulties with breathing, which we kind of passed off to, you know, she'd put on a lot of weight. She'd had the C-section. Her breasts were swollen, you know, from lactation. We were just looking at all these signs as like, it's just normal because you've been slightly eviscerated and everything else. So what we didn't know was that she was having issues. We were discharged on Sunday. That Tuesday, I had gone back to work in the morning. She had gone to the doctor with her brother, with Sophie. She was experiencing a lot of shortness of breath at that point, so we just basically he got her back home and put her to rest. And I came home from work that afternoon. I'm exhausted, so I go to bed at around 11, and she wakes me up at about 12:15, and she's like, I need your help. And I'm like, well, what's the problem? She goes, I can't breathe. And to me, it looked like she's hyperventilating. She's just getting very anxious and she's getting very excited, you know. She hadn't had a lot of sleep. She was having a lot of issues, and I just was like, she's hyperventilating. So my job is to calm her down. So there's no warning bells going off in my head at this point. I'm not thinking I need to call 911 immediately. I'm not thinking I need to put her in the car and take her to the hospital, which is literally 5-7 minutes from here. She is devolving rapidly in front of me. She's, you know, asking for cups of water. She's asking for cups of ice, and she's dumping it over her head, and her arms are just, you know, this. At that point, I'm like, okay, I don't know what's going on. So I called 911. And in the span of that call to them arriving here was probably about 7 minutes. She went from standing to sitting to laying on the floor to not breathing. The last thing she said to me was, I love you. They basically put her on the board, took her out of the house, and kept working on her. It took them 25 minutes to establish a pulse. Over the course of 2.5 weeks, that's how long she stayed with us. I think I said, I'm sorry to you every single day. You trust what the experts are telling you. You trust that the people you're dealing with are telling you everything you need to know. You trust that they're being honest with you. If there was something to be concerned with after the delivery, because the cure for preeclampsia is delivery, you're out of the woods at this point. And nobody's telling me otherwise at that point. So everything that happened after it, you blame yourself for because you're not paying attention. Should I have gone on and looked up preeclampsia on the web? Because, hey, you know, the internet's a great thing now. Should I have looked it up and been aware of it? Would have, should have, could have thing. Everybody says, well, don't blame yourself, but, you know, that's easy to say. It's another thing to be the individual that was the one witnessing everything that happened here and supposed to be the protector of the family. Why not be taught about help? Why not be taught about some of the risks that are associated with what you currently experience? You know, the cancer patient certainly knows what their risks are when they start taking chemotherapy. They know what they're in for the long haul. Preeclampsia, you know, if it's been debunked that delivery is the cure, be honest about it, you know? You know, the ending doesn't change. There's never a happy moment that comes from it. But if somebody else can live because they've heard this story and understands, you know, what preeclampsia is and takes it a little bit more seriously, when talking to their patients, or as a patient, they understand what the symptoms are and they're not afraid to speak up, then something comes from this. And that's what I hope.
So I thought like, it was a great video they shared with us.
Yeah.
But I thought like, this just shows that we have a lot of work.
Well, I'm
Work
not-
to do, educating.
Right,
Yeah.
because, I mean, I'm not an OB nurse, and if I'd had a patient come
I
in,
haven't seen the sun in like
it would never occur to me, oh, well, she just had a baby,
Sunny beaches, sandy beaches, blue beaches.
Right.
3 weeks ago, maybe this is,
Maybe she's having some,
you know, do
Yeah.
I need to ask more questions?
yeah.
Hands up, I'm spotted at Perfect Beach House.
I'm sorry, let me see if I, okay. So, yeah, and again, like, a lot of the work is for our department to do and getting the word out, but I just think, I was like, oh, I just want anybody who could, these women could, they could present to the ER and be like, right, and if you, and it's that question,
Yeah,
like,
because, I
Did she
mean,
say she
the only
had a
thing I knew
C-section?
about.
she did have
it was-
C-section, which
So
is,
wouldn't you have been wondering about an PE or something, since she was having such profound shortness of breath?
yeah, for sure, but
Or-
there you go. Yeah, but and I mean, not like pointing blame, but obviously, you know, and just as you thought coming into this is like,
Yeah,
oh,
we
isn't
thought
the
that
cure?
was-
You know, like you're,
didn't
once
know
the
that.
baby's out,
Yeah.
you're fine, but
That's all I,
but you're not.
that's as much as I knew about.
Yeah, and that's when I first started OB, it's like,
Yeah.
but really we need to
So,
shift our
Do
thinking.
they keep them maybe when they're having preeclampsia and a C-section? Do they keep them a little longer?
Yeah, so
She went home quick.
she went pretty quick, probably, yeah.
And they
Um,
didn't consult with her specialist doctor, which is bizarre.
Right, so there's
There are a lot
That's
of,
a
a lot
things
of
that went
things
wrong in
where
his story, yeah.
in his story and his interpretation of the story, and pretty scary, but yeah, and there's, you know, the risk factors for preeclampsia. I just wrote some of them down, let me get to that. Like a first-time mom is more at risk for
She was 42.
well, yeah, and advanced maternal age is a huge, multiple gestation is going to be a mom who has kind of chronic hypertension before pregnancy is going to be more risk for developing it. So, let me just get, yeah, diabetes actually, not gestational diabetic, but she
But she
was
was
diabetic.
diabetic.
She had a lot of those classic obesity and multiple gestation, as I said. But yeah, so I just thought like, oh, that video really hit home. Like, okay, like let me see if I can get to the slideshow here from current slide. Huh? Okay. So then these were some key terms that I didn't know. And this pertains more to mortality. But the state does, or in the country, they're tracking this, but if I just take to the state level, they did add in the last, I think it was maybe in 2010 or 11, they were referring to, they added a new box on the death certificate so that we can be addressing this important question. So a pregnancy, the terminology is so tricky, but a pregnancy-associated death is the death of a woman while she's pregnant or within 1 year of the end of the pregnancy, regardless of the cause. So it could be, so that's why it's important for tracking purposes. If you had a motor vehicle accident woman come in, a childbearing age, somehow trying to ask, has she been pregnant within that year? Pregnancy-related death is the death of a woman during pregnancy or within 1 year and from a pregnancy complication. So that's getting a little more specific, so that's gonna probably take out the motor vehicle accidents or that would be more for the preeclamptic. A chain of events initiated by pregnancy or the aggravation of an unrelated condition by the physiological effects of pregnancy. That could be, I wonder if you could, the mental health component, with postpartum depression, things. And then maternal mortality is the death of a woman related to or aggravated by pregnancy. It's not due to an accident or incidental causes, and it occurs within 42 days after delivery.
How did they come up with that number? 40 days?
Yeah, I know.
Where do you get these
Well, I
numbers?
think it's 6
Just studies
weeks.
of- okay.
6 weeks postpartum. So I put that definition there. It was later in the slide, but then I put it up. Yeah, I wanted to put it all throughout because it's so confusing. So then the CMQCC, that's one of the collaboratives that I work with, that I use their resources from. And this is pretty old data, so I recognize this, 2002 to 2004. But so the interesting part to see was that of 25 women who had preeclampsia and died, right? 16 of them were from stroke. Okay, and of those 16, 16 of the 25.
14 was of the 16.
14 was hemorrhagic, and 2 were thrombotic.
Oh, sorry, I misunderstood.
Yeah, it's yeah. So 16 of that 25 were from stroke. Then 4 were liver failure, cardiac failure, DIC. But stroke is huge. So I thought that was interesting for ER folks to see. This was interesting how it just kind of extrapolated that there was a delay in diagnosis in 22 of the 25. And there was a misdiagnosis in 13. And ineffective treatment in 19 of the 25. So hence more education, more, So I thought, okay.
Does misdiagnosis mean not diagnosed at all?
Yeah,
Or
or
they didn't know they had a problem at all?
I guess so, yeah. Or
And this is talking about the physiological reason why you're more likely to have a hemorrhagic stroke with preeclampsia. I mean, these people also have concurrent health, or?
I don't,
Because
of the blood pressure?
yeah,
Yeah,
they're
blood
hypertensive state.
But I mean,
Yeah,
right, but you can be hypertensive doesn't necessarily make you,
makes you more at risk for stroke.
sure, but I mean, the majority of those are.
And they've got a lot more
But-
blood volume.
but
in
DIC
their
was only
bodies.
1 out of the 25.
Mm,
They have a lot
Yeah,
more
but
blood
14
volume
don't
that
have
they're dealing
hemorrhagic.
with.
Right, that's what I'm saying,
Yeah.
because they're not saying that a big portion of those also had health,
No.
no.
Nope. So that's pretty old data, but it was just interesting, and I'm sure that was the impetus behind we gotta get active. In Maine, these are the severe maternal morbidity conditions that particularly Maine is tracking. Acute MI, acute renal failure, are amniotic fluid embolism, aneurysm, cardiac arrest, DIC, eclampsia, heart failure, arrest during surgery. Oh, the next slide is so much more interesting. Let me just skip to that because it shows current data from 2013 to 2015 in Maine. I thought this was interesting. So look how many, oh, you can't see, but heart failure during procedure or surgery, 73, that was the highest number. And that just shows like, you gotta keep them out of the OR as best we can.
Right.
Which gets into like a whole can of worms of, it gets into induction and, you know, like, there's so much work. But anyway, so that patient who's had surgery should it'd be a red flag for us all. Oh my gracious, how'd that happen? Okay. DIC 67 per 10,000.
It's crazy how radically it went up. Those numbers.
Oh, well, you mean over 13, 14, and 15?
Oh, that's the
No,
years, I see.
these are the years, I just
Right.
then,
I
yeah.
see it's cumulative.
So it's actually going down,
Right.
kind of went up, but these are kind of our big conditions that the state's tracking, and of course transfusion. So that's going to be linked to our hemorrhage. This was, and again, this is Maine data. I just thought it was interesting to pass along. So between 2014 and 2017, there were 30 pregnancy-associated deaths. So I got to get my definition out again, because see, that's where I want to put it everywhere. So pregnancy-associated death is, again, the death of a woman while pregnant or within 1 year of the end of her pregnancy, regardless of the cause. So, and you can see, the next slide shows it a little, it's the same data. 50% of those deaths were caused by accident. So accidental poisoning. And then we asked, like, is that drugs? Like, that could be a drug overdose. They couldn't pull out that data. Suicide, car accident, homicide, drowning. There were 11 deaths cause related to or aggravated by pregnancy up to 42 days after